Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for December 11th, 2024. Thank you for joining us today, and thank you to the current Osteoarthritis Action Alliance sponsors shown here who help support our work, which includes the monthly Lunch and Learn webinar series. Our presenter today is Dr. Lauren King. Dr. King is a rheumatologist and clinician scientist at St. Michael's Hospital in Toronto, Canada, and an assistant professor in the Department of Medicine at the University of Toronto. Her clinical research program combines epidemiology and implementation science with the goal of identifying gaps in care and developing evidence-informed solutions to improve care and outcomes for people living with osteoarthritis. The title of today's presentation is The Opportunities and Challenges of Early Knee Osteoarthritis. Welcome, Dr. King.
Thank you. Thanks for the introduction. Thanks for the opportunity to speak today. I'm so delighted. I'm coming from University of Toronto, and so I'm actually right in the middle of my clinic day. I'm at St. Michael's Hospital, and the hospital, St. Michael's Hospital, one of the U of T affiliated hospitals, is actually within walking distance of the CN Tower that you can see in the photo there. Yeah, I can imagine it's a lot warmer in North Carolina than it is in Toronto, though, in December. And this is not an accurate depiction of what December looks like. Toronto in December looks like. Here are my disclosures. So in today's brief talk, I'm going to go through the concept of early knee OA, the specific opportunities that studying this group might provide, and then describe an international effort to develop classification criteria for early stage symptomatic knee osteoarthritis to try to realize some of these potential opportunities that I'm going to be speaking about. Okay. So first of all, what is early osteoarthritis or early knee osteoarthritis? And while you take a moment to think about this, I'm going to say that I'll be focusing on the knee since it's responsible for not only the greatest burden of OA, but for better or for worse, it's where most of the research is, and also keeping the topic contained for this short talk. So early OA, as you've probably in your reflection kind of thought about, it can mean a lot of things. And early knee OA can be used to refer to OA that develops at an early age. Sometimes it gets used to refer to individuals early in the course of OA when they first start to develop symptoms, irrespective of age. And it also gets used to describe the illness of OA when individuals may not have much in the way of structural changes on X-ray, for example. And all of these definitions are potentially valid. But when it comes to the opportunities of early knee OA, I'm going to be speaking to one specific entity that we've called early stage symptomatic knee OA, or ESCOA. And the concept here is someone with the symptoms at the knee that are due to OA, but without having established radiographic OA. So really, individuals who may not have joint space narrowing on X-ray. And for sure, when we do a deeper dive into these individuals with MRI, for example, many of them may have structural changes like cartilage lesions, but absence of joint space narrowing is this line in the sand that denotes a certain threshold of structural severity that can be communicated in a way that we can all understand. So I'm going to make the case that when we're talking about developing novel treatments, advanced therapeutics, there are some distinct opportunities of studying individuals with ESCOA when it comes particularly to the development of anti-catabolic disease-modifying therapies. Okay, so why might ESCOA present an opportunity? And again, ESCOA being that entity where you have symptomatic knee OA, but without established radiographic OA, without radiographic joint space narrowing. So let's think about who might be an ideal participant to enroll in a clinical trial of a potential new disease-modifying therapy. And so we'd be looking first for people with symptomatic knee OA. Regulators are not in the business of approving therapies for people without symptoms. And in the context of developing an anti-catabolic disease-modifying OA drug, or DMOD, so a therapy designed to potentially slow the disease process, you'd want to test it at a point where there's sufficient organ that's intact since you're looking to preserve or slow the structural changes in the joint. So we'd want individuals with minimal structural changes. And again, really ideally, we don't want to be putting people into trials who already have the established or advanced structural changes that we want to prevent. So we'd be looking for people with minimal structural change. So I'm a rheumatologist, and I'm going to make a comparison to rheumatoid arthritis. And so in RA, we have several approved disease-modifying anti-rheumatic drugs that are called DMARDs, and they've been shown, lots of evidence show how they can slow or even halt the disease progression. These are medications like methotrexate or adalimumab. And in clinical practice, the idea is we want to identify and diagnose individuals with RA early before they have these bad structural changes like erosions, and treat them with a DMARD to prevent structural change. And so just like with DMARDs, of course, we don't have any approved DMODs in OA, but the idea is ideally when it comes to developing new therapies, we evaluate these disease slowing or halting agents in a population where it makes sense to target them. So there may be an opportunity to see more favorable outcomes in clinical trials of novel OA therapies if we can identify and test these therapies before there are multiple biochemical derangements that we know are present in OA, and before they become beyond the point of no return, and before there are irreversible advanced structural OA changes. So with that in mind, who's actually getting into OA clinical trials right now? Typical enrollment criteria for trials include symptomatic radiographic OA. So in practice, this means a certain threshold of pain, like 4 or more on an 11-point numeric rating scale. And this means also typically Kellgren and Lawrence grade 2 or higher in terms of radiographic change. So having established radiographic OA that includes the possibility of having joint space narrowing. So many of you are probably familiar. KL is this really old way to grade the severity of OA changes on X-ray, from 0 being normal radiograph to 4 being advanced joint space narrowing, severe sclerosis, large osteophytes, and other changes. Many trials may not enroll individuals with grade 4 changes. Those are very advanced, and it's typically the grade 2 or 3 that are getting into trials. But then there's this group of individuals who are largely missing from being enrolled into clinical trials. So those with less structural change, so symptomatic OA with Kellgren and Lawrence grade 0 or grade 1. Inclusion criteria for trials also sometimes rely on the 1986 ACR classification criteria for NEOA developed by Altman and colleagues. And you can see just by the font of the screenshot there that these are indeed very old. These were largely developed to discriminate OA from other forms of arthritis in tertiary care. And you can see how some of the items in the Altman criteria reflect this, like inflammatory markers, rheumatoid arthritis serology, the rheumatoid factor there, synovial fluid analysis. And we know that the Altman criteria, they've been shown to miss a large proportion of individuals in the community with symptomatic NEOA. These really identify individuals largely who have long-standing OA and advanced structural change. So again, not the target population we may be interested in for a clinical trial of a potential DMOD. So I'm going to illustrate the theory here. So on this schematic, we see in that star, we're introducing a potential therapy in an individual with established OA. And if you work with me here, by introducing it at this point, when they have established NEOA, it doesn't really do much in terms of the trajectory of their disease. But what if we introduced it earlier in someone with early stage symptomatic NEOA? Perhaps this could lead to a more favorable outcome. And so there may be this window of opportunity that if we could identify and enroll people with symptomatic OA before they had established structural change, well, maybe the DMODs could do a better job, particularly when we think about the DMODs that aim to slow or halt disease progression, move the studying of these therapies upstream. And so while the evidence to date for this theory is still limited, we can't even identify people with a SCOA yet in a standardized way. There are some data to start to support this theory. And I'm going to give an example here. So in a post hoc secondary analysis of the loracivivant, which is an articular modulator of Wnt and other inflammatory pathways, we started to see that there was more likely to see a beneficial treatment response in those who had less structural change at baseline. So this figure is from a recently published paper, and in the figure on the left, these were individuals who were Calgren and Lawrence grade 2, compared to the figure on the right that are Calgren and Lawrence grade 3. And so if we focus on the one on the left, you can see that there is a separation between the blue treatment arm from the kind of gray placebo arm in this Calgren and Lawrence grade 2 group compared to the Calgren and Lawrence grade 3 group, where we don't see this separation. And the outcome here, as you can probably see on the figure, this is average pain. So this doesn't tell us about disease modification. But here we do see greater symptomatic benefit in patients with less advanced structural findings of knee-OA. And so while there may be some real opportunities of expanding who's enrolled into clinical trials to include those who have knee-OA without established structural change, there are also several challenges, like how do we capture these individuals in a way that's useful for drug development and testing? Right now, there's no validated standardized way to identify these individuals. And then maybe a more philosophical question is, is our field prepared to change our concept of OA and move it more upstream? Okay, so I'm going to speak now about the early stage symptomatic knee osteoarthritis initiative. So recognizing this research gap and the opportunities that testing therapies in people with ASCOA might afford, the ASCOA initiative was launched in 2021, and this was under the auspices of the OA Research Society International, or ORSI, and is made up of a bunch of researchers from all over the world really committed to this multi-year, multi-phase initiative to develop classification criteria for ASCOA. So here's an old photo from some of the group, but there's actually about 10 of us who meet on a regular basis to try to advance this work. And key here is Tahina Nyoji with the peace sign there, who's the chair of the methodology working group. And then putting her hand up waving is Jillian Hawker, who chairs the ASCOA Initiatives Steering Committee. So what are we trying to achieve with classification criteria for ASCOA? Well, we want a set of criteria that can be used to identify and enroll individuals with ASCOA into research studies, including clinical trials, in a standardized way. And this will facilitate not only studying people with ASCOA, being able to pick them up, but ensure the comparability across studies. These criteria need to be able to discriminate individuals with ASCOA from those with other causes for their knee symptoms or mimicker conditions, and those with established radiographic knee OA. And the idea is that these criteria, eventual criteria, will be applied to individuals presenting with knee symptoms. What's really novel when it comes to the ASCOA classification criteria initiative is we're not just expanding existing criteria like have been done in other diseases to move a little bit earlier on in the disease, and that's been done in rheumatoid arthritis and in lupus, but we're actually trying to develop classification criteria for this early disease entity alone. As a reminder, classification criteria are not diagnostic criteria. The purpose of classification criteria are to create these homogeneous groups for research studies. They're not intended to capture all patients with the condition. Classification criteria really prioritize high specificity, so having few false positives at the expense of sensitivity. So we're willing to accept, false negatives. And for this reason, classification criteria may not be suitable for use in clinical care, because if you rely on these, you may miss people with the condition of interest. So we set out on an approach to developing classification criteria that follows established ACR-EULAR methodology. And this approach has generated many successful classification criteria sets, like those for systemic sclerosis and lupus and RA and gout and many more. And just in terms of an overview, the process starts very broadly with generating a list of all the factors or variables or items that should be considered. And then we use data to narrow down this list. And then in the third phase, it's around generating the criteria using an evidence-informed consensus process, so drawing on multi-criteria decision analysis. And then finally assessing the performance characteristics of the criteria in independent samples, so one that we haven't already used as part of earlier analyses to avoid circularity bias. So we've just completed phase one, where we've filled our bucket with candidate items across a number of domains. And these are candidate items or variables that could be potentially useful to classify an individual as having a SCOA. And again, this was about trying to make sure we have had anything potentially relevant added to our bucket to take to our second phase, where we're going to look at more closely in some data analyses. And so I'm going to share a bit about the work to get here. So our phase one work. So the first study in phase one was a scoping review led by the incredible Jean Liu from Boston University to understand how early stage NEOA had been defined in the literature to date. And this study confirmed that there was no single way that early stage NEOA was defined. In fact, it was highly variably defined with these different elements across different domains used in the definition. So it was clear that there were differences then in the underlying concept of early stage NEOA used across the studies that were included. And so, for example, 70% of the studies had included imaging as part of their definition of early stage NEOA. And in fact, most often this was actually having the presence of Kellgren and Lawrence grade 2 or higher structural changes. So many of these definitions required radiographic change to call it early OA. And so that's obviously very different than our underlying concept of a SCOA. But despite these differences in the concept, we pulled out the most frequently used elements from the definitions within each of the domains, and I've provided some examples there after the arrows, so that we, to give us a sense of, I guess, what researchers had identified as potentially important things to consider for us to take to our subsequent Delphi study, and I'll explain about that in a moment. The next study we completed was a qualitative descriptive study of individuals with NEOA to understand their first recalled OA symptoms and experiences. And this was done importantly and explicitly to incorporate patient perspectives into item generation. We analyzed focus groups and one-on-one interviews that were completed in 91 individuals with NEOA. And this was a secondary analysis. These interviews came from a prior study done to evaluate the OA pain experience. And from the data, we constructed 4 overarching themes. So participants described this insidious onset, this gradual and intermittent way in which symptoms of OA developed, often over many years, and many of the participants couldn't identify a specific starting point. Participants described really a diversity of early knee symptoms or initial knee symptoms, and this included, things that were familiar with hearing, activity, exacerbated joint pain, stiffness, and crepitus, but there really was a heterogeneity in the specific manifestations or symptoms that individuals recalled as occurring first or early. Many individuals described having dismissed their early knee symptoms or really rationalized their presence, often feeling like there's or describing to us that they kind of felt at the time there's no way these knee symptoms could be due to something chronic like arthritis, has to be due to something else. And then finally, participants described how they initially used these compensatory strategies for their first symptoms. They made adjustments in their daily life to allow their daily life basically to look pretty normal, allow them to complete their daily activities. And it was only when they couldn't compensate anymore that the OA became more top of mind and they sought care. So this study helped us in a couple of ways. So first, it helped us as a group to better understand the early OA experience. These results underscore how it's challenging to identify people with NEOA early in its course. People aren't even presenting to care until it's been going on for a while. And this supports the development of specific classification criteria for a SCOA. And secondly, this provided some specific manifestations that individuals described early in the course of OA that would contribute to an initial list of symptoms used in our Delphi study. Okay, so now to talk about our Delphi. So really informed by the scoping review and the patient qualitative study, we completed a 3-round international modified Delphi exercise with OA clinicians and researchers from 6 continents. And the goal was to continue to generate items starting from what we had learned in the prior studies, and then gently reducing the items to a more manageable number to take to data collection phase or data analysis phase, recognizing that this was still phase 1 item generation. It was only a mild reduction that we wanted. So in round 1, 128 participants across a range of disciplines reviewed a list of candidate items and then nominated any additional items they felt might be useful to either discriminate someone with a SCOA from another condition or from established radiographic OA. And we then added items nominated by at least three participants or 3 respondents to this master list of items that we had. And then the next 2 rounds were around rating the items. So in round 2, participants rated the usefulness from 1 to 9, completely useless to completely useful. And in round 3, participants could see their rating, the group median and quartiles, and re-rate the item if they wanted. And after round 3, we retained items as long as the median rating was at least 5 out of 9, and a third of respondents rated the item as 7, 8, or 9, so that most useful end of the scale. And this left us with 66 items. We then did one additional analysis. So we analyzed the round 3 ratings using the same cutoffs, but separately within the largest clinician groups who responded. So that was rheumatologists, orthopedic surgeons, primary care providers, and physical therapists. Because we recognized that different disciplines would bring different perspectives or different lenses. And this, in fact, resulted in 11 additional items that had been removed because they weren't rated high enough overall, but coming back. So that left us with 77 items that we retained that spanned a number of domains, as you can see in the yellow. Okay. As a counterpart to the Delphi that was done, as you just heard, in the OA health professionals and researchers, and again, recognizing the importance of patient input, we completed an international patient survey around the first manifestations of NEOA to overcome really some of the limitations of that prior qualitative study that was a secondary analysis. And so we had 92 participants complete the survey. Individuals were recruited from 4 countries, and the OA Action Alliance was involved in recruiting. So thank you very much for that. And here in this study, about a third of participants were within the first 5 years of symptom onset, and all had to say, yes, I recall my initial knee symptoms to be eligible. So looking within the first year, or describing symptoms within the first year, it was in free response. The majority of participants recalled having, I should say, we actually asked them to indicate, first of all, if they recalled changes to how their knee looked, felt, and moved. And the majority of participants did experience that. And then we asked individuals to describe in as much detail as possible within those categories, their symptoms. And we conducted a content analysis of these free response descriptions of their symptoms. Within each of those 4 broad categories, people were also asked to describe changes to their overall state. And so this study helped confirm that the patient's frequently reported symptoms were covered by the items that we retained in the Delphi study. And that, in fact, that those items that we were bringing forward after phase 1 really reflected patient preferences or patients' experiences. Okay, so now that we have our bucket full of candidate items, we're preparing for phase 2. And so this will likely require some primary data collection, but we're also looking to existing cohorts to see if we have data that might be sufficient for some of our analyses. And we're trying to develop our evidence base for the candidate items alone in combination to be able to discriminate a SCOA from mimicker conditions and from established radiographic NEOA. And so I think there's a lot to be optimistic about while we're still at the start, and SCOA is not without its challenges. We're following a robust methodological approach to developing classification criteria. And we see this as an opportunity. I think we're all motivated by this potential ability to facilitate the development, testing, and ultimate approval of new disease slowing away therapies. So, in summary, while there's a strong rationale to test D modes in people with a SCOA, this is currently not being done in large part because we have no standardized way to identify these individuals and put them into clinical trials. And to be able to seize this opportunity of a SCOA, or see a SCOA initiative is developing classification criteria, and we're well on our way. And we really have hugely benefited from the support of the greater OA community. So thank you on behalf of the SCOA initiative. And so thank you very much for the opportunity to speak. I'm happy to answer any questions in the time remaining.
Thank you so much for that presentation, Dr. King. We do have time for one or two questions. So if you do have a question for Dr. King, feel free to type it into the chat and I will read it aloud. Dr. King, one thing I was thinking about as you were speaking is, a lot of this is focused on kind of research implications and enrolling patients with early NEOA into drug trials to try to find that disease modifying drug. But generally, what would you say so far that you've learned in all of this research as far as how this might affect just even your, as a rheumatologist, your clinical care of patients, or for a primary care provider, their care of patients who may have these early symptoms?
So I think that's such an important question. And I think over the last couple of years, being engaged in this work has made me think about it deeply in many ways. In terms of the clinical aspect, maybe I'll cover that first. It's not that classification criteria can't act as diagnostic criteria. If you have classification criteria that, when you look at the operating characteristics or the test characteristics are highly sensitive and highly specific, then they can operate, or they can work well in terms of potentially as diagnostic criteria. But we don't design them to optimize sensitivity a priori. So that's one. There is the potential to guide clinical care depending on what the operating characteristics of the eventual criteria look like. I think just overall, I think it brings more recognition to the idea that OA is an important disease, and that as a rheumatologist, I know I'm not seeing people early on for the most part. When someone gets referred to me, this has been going on. Symptoms have been going on for quite some time, and we really heard that in our research to date. And I think it's an opportunity for the community to really start to understand where people will present to early, as a way to guide eventual interventions of where we can pick up these individuals, where we can recruit from, where we can study them, and where we can increase awareness of osteoarthritis at.
Well, that's really important, and I appreciate that perspective. And I also was, just appreciating the role of patient perspectives that you are putting in many of the phases of your work. So that's very important. In addition to obviously the expertise of and research components that you're identifying. I don't see any other questions in the chat. I will open it up. If there are any questions, feel free to type them in, and we'll go ahead just with a few housekeeping things here. Just want to remind everyone that we hope you'll join us in the new year for our 2025 Lunch and Learns. Our first one will be on January 15th, featuring Dr. Stephen Messier, who will speak on the behavioral interventions to manage obesity and osteoarthritis. You can find the link to register for that in the chat. And I will be launching a poll here if you don't mind responding to that before you leave, just for a little feedback on our Lunch and Learn series. And Dr. King, thank you again for taking time out of your busy clinic day for this presentation. And thank you to everyone who attended the talk today. Dr. King, do you have any final words or anything you'd like to end with?
It's just such a pleasure to speak to a group that's doing such important work. So kudos to all of you, and it's a pleasure to be part of this community.
We appreciate your time and expertise. And that concludes today's presentation. Thank you and have a great day.